Olá, viva, sejam bem-vindos a mais um episódio do LungTalks, um podcast da Sociedade Portuguesa de Pneumologia. Aqui vamos continuar a conversar com os especialistas para explorar os mais recentes avanços e inovações tecnológicas e também os desafios da medicina respiratória, que é uma área, como sabem, em constante evolução. Com grande entusiasmo que continuo esta jornada com uma série de episódios dedicados à pneumologia de intervenção, onde estamos a abordar de forma descontraída e informal os temas que estão na linha da frente do desenvolvimento científico e tecnológico nesta área. O meu nome é Hélder Novaes e Bastos, eu sou pneumologista no Hospital São João, no Porto, e continuo a ser aqui o vosso anfitrião nesta série. Fiquem, portanto, connosco aí para uma conversa que vos liga à inovação. Hoje vamos discutir um tópico que, a meu ver, é crucial na pneumologia moderna, a importância de estabelecer uma equipa ou um serviço de pleura, ou em inglês, a Pleural Team, Pleural Service. E para discutir este tópico fascinante, tenho hoje a companhia do Josué Pinto, que é responsável pela consulta de pleura no Hospital São João e a quem coube essa muito desafiadora tarefa de organizar um serviço focado na patologia pleural no nosso serviço. Vamos também ter o privilégio de receber dois renomados especialistas globais em doença pleural, que estão hoje conectados do Reino Unido. It's a great joy to introduce Professor Najib Rahman and Professor Ehab Badawi. Thank you both for staying here with us. Najib Rahman directs the Oxford Respiratory Trials Unit and works clinically as a pleural specialist at Oxford University Hospitals. He has conducted several randomized clinical trials and also observational trials in pleural infection, pneumothorax, and malignant pleural effusion. Has published over 300 papers, so it's a co-chair of several guidelines in pleural disease, and it's very honor to me to have you in this podcast episode.
Very nice to see you.
I'm also welcoming Ehab Badawi. He's also a consultant in pleural and respiratory medicine at Oxford University Hospitals. And he was, until recently, based in Sheffield teaching hospitals, where he also promoted the pleural service. His PhD thesis focused on outcome prediction and early intervention in pleural infection, including the MIST-3 trial. This was the first multicenter randomized controlled feasibility trial of early combined fibrinolytic enzyme therapy versus early surgery. Welcome, Ehab.
It's a pleasure to be here. Thank you. Thank you for having me.
So in today's medical landscape, so specialization and multidisciplinary collaboration are key to optimize patient care. And that's exactly what the pleural team, the pleural service is aimed to achieve. So to start, and I will ask you both, and also then I will understand the challenges of Ehab in UK and Josué here in Portugal, Porto. So would you explain exactly what a pleural team or pleural service is and what is primary mission? So I will start, with Najib, and then I'll just go to the challenges with Ehab and Josué in both centers. So Najib, what is a pleural team, a pleural service?
Sure, thanks, Helder. I think this has been more clearly defined in the last 20, 25 years. I think we need to start at the beginning. So pleural was always under the brand of respiratory medicine, and there were in fact a number of different professional groups that did pleural disease. There's A&E, medicine, surgery, ICU, radiology, and then respiratory. But since pleural became a subspecialty in its own right, which I would say it did in the early 2000s because of the first BTS guideline published in 2003, 2004, the issue is that there are a number of different moving parts to the pleural service. There's increasing evidence and therefore increasing complexity. So the pleural service, I think, accommodates individuals who are trained within pleural intervention techniques, of course, but perhaps more importantly, have training in diagnostic techniques such as thoracic ultrasound, and also expertise of the various disease areas, which broadly, of course, are malignant effusion, undiagnosed effusion, pneumothorax, infection, and then lots of other rare things. So I think the pleural team are people who are dedicated with the correct expertise to the diagnosis and management of people with all forms of pleural disease. So it's not a pleural effusion service, it's not a pneumothorax service, it's everything to do with pleural disease. And my own view is that if you have people who are dedicated to it, you will get better outcomes for your patients, you'll get better protocols in there, and these people then can keep up to date with the latest studies, which are being published all the time and shifting our understanding.
Yeah, so that's how many people do involved in the pleural service? Are just physicians and fellows? Do you also involve the surgeons? Do you involve you have dedicated nurses? So if I wanted to start a pleural service myself, who should I ask for collaboration?
Sure, thank you. So I think the core membership of the pleural team are you need a respiratory physician who's well trained, and I think it has to be a respiratory physician. This is very much our area. I think within our team, we have several physicians, several fellows, and then several nurses, and that's the core of the team. But there are immediate adjacencies to other services, and the key ones are radiology, pathology, surgery. Those are the key ones. You need to have good working relationships because we will constantly be asking the pathologist to stain for IgG4 or asking the radiologist whether that pleural thickening can be biopsied under CT or asking the surgeon if they can do an empyema surgery. So, and oncology as well, I think these are the core team adjacencies that you need. I don't think they need to be a core part of the team necessarily, but actually within our service, we have a lot of to and fro.
Ahab, you had a good former experience from Oxford. You moved to Sheffield. Now you're coming back to Oxford. So you came from pretty well established in the the example of what is a pleural service. Moved to Sheffield to promote further some. I don't know if it was at that time an embryonic pleural service and a pleural team. What were the main challenges you faced at starting your idea? What is a pleural service in Sheffield?
Yeah, thank you, Helder. So I think when you're coming to start a pleural service, I think what you have to do, first of all, the biggest challenge is trying to convince your managers, your department, your hospital, that this is something that you need, first of all. Because I think in some parts, I think in well-established centers, I think it's quite easy for us to see, especially as, people with significant pleural expertise and awareness of the literature, that of course it makes sense to have a dedicated pleural service. But then you need to be able, for it to work, you need to convince the whole hospital machine, if you like, that this is something that needs investment and something that needs growth. And I think really the first thing to do for those who are listening, who are interested, for example, who don't have a dedicated pleural service, is there's very easy sort of audits or data that you can look at. Go and have a look at the time to diagnosis of pleural malignancy in your hospital. Go and have a look at how many unnecessary procedures or procedural complications are being being carried out in your center. I mean, the chances are that there may be even procedures being done that are not reported or are not aware of, because these are this is one of the things that a pleural service brings in, sort of, established, structured reporting systems for pleural procedures. Go and look at the outcomes for patients with malignant pleural disease, patients with pneumothorax, patients with pleural infection. Go and have a look at the number of times patients with pleural effusions are getting readmitted to hospital because they didn't get managed correctly the first time, or the pleural effusion didn't get diagnosed correctly. And then simply have a look at sort of things like length of stay. Look at things like, patients sitting with a chest drain, waiting for, a surgical opinion, for example, when actually they could have been discharged and, come back and been seen as an outpatient. So I think as Nige says, I think the key things is that pleural disease has become more complex. And I think once you show all this data, and once you show that some of the things can be done better, and that you can improve all these things by dedicated pleural expertise, then people start listening. Then the next step then becomes obviously the investment. And I think everything that I've just said forms the basis in terms of how you then start writing up your business cases to obtain a thoracic ultrasound machine, for example, to have a dedicated endoscopy suite, for example. This is one of the things that we did early on. Is, we were only allowed access to a dedicated room, twice a week, for example. So if you presented, on a Monday or a Thursday, we could see you on that day, but otherwise we would have to, for example, see you, but bring you back the next day for a procedure. And what we managed to do with time is, because we were constantly overbooking those lists and showing how much demand there was, we managed to then expand the service onto sort of a 4-day a week access to, because our department and our management could see what the need was. And then once we then started at the beginning, obviously, because we didn't have fellows, we didn't have dedicated nurses, we didn't have, it was just basically me and another consultant physician. So what you have to do is what we had to do was be very open access. I couldn't say that I'm only happy to be called on a Monday afternoon or a Thursday morning. I basically said, just open access, email me, call me anytime, and then people start seeing that the benefits. Actually, we had a dedicated plural bleep and a plural email, generic sort of plural email. People would start sending every time there was a plural case that referred to emergency department. Before they do anything, they would call us, and within a 2-minute phone call, review the patient. Actually, a lot of the time patients can be just discharged straight away. The emergency physicians love that, because they didn't need to do anything for the patient, and they knew that the patient already had follow-up with a specialist who could give a good opinion and who could then sort them out and take them off their caseload. And then obviously the MDT, for example, knew that if, for example, any patient with a pleural effusion, rather than being busy under the lung cancer MDT that already had, for example, 40 patients on it, any patient with a pleural effusion could be sent to the pleural service, and they could effectively and very efficiently diagnose and manage that case. So I think that those were the initial challenges. I've given you a very long answer, and I've gone on for a very long time. But I'll just to close. I think some of the challenges when I reflect is just with time, very quickly we had to be a very open and very busy set of clinicians. But then as you start to sort of focus on the areas that you can develop, then people start to see the need, and then actually you end up being a very popular service within the hospital, because you could take a lot of work off people, and actually the patients find it excellent as well.
So you must be committed.
Yes.
And accountable for the patients and also for our colleagues. And it's all about improving care with the standardized care. So what you should do. So you're focused on that specific topic. So every patient with that kind of disease will be have the same outflow of their diagnosis and treatment. So I think that's one of the tangible benefits that we can find. And so who's referring you? So you said you have an email, you have available phone calls. Who's referring the patients to you? Are all the pulmonologists, or beyond pulmonology department, the internal medicine, thoracic surgeons, outside your own hospitals in Sheffield and Oxford?
So the short answer to your question is everyone. We get referrals, and even Naj can attest to this in Oxford as well. When I was a fellow there, literally emergency department, acute medicine, cardiology, intensive care, surgery, we get referrals from everywhere. And I think the more established you are, I mean, Naj obviously can attest to this more than me, is the more established you become, the busier you get, because absolutely people people realize the value of getting involved with you, getting you involved early on in the patient's pathway.
Helder, can I just come in? I mean, look, I completely agree, of course. I had an experience when I started in Oxford in 2003, 2004. And at the time, my previous mentor, Rob Davis, he did thoracoscopy, and he had a pleural clinic, but that was it. There wasn't really a pleural service. It was just a specialist pleural X. And over 3 or 4 years, we established the specialist pleural service. My biggest learning from that is you and I have to add value to patients. That's the whole thing. And Ehab's very eloquently demonstrated that A&E call you, and you give advice. Either you go and sort the patient out or you get them on a pathway, but you have to add value. What I teach my fellows more than anything is we must not be the people who turn up and say, I'm not doing an intervention, and then walk away. Because we're not technicians, right? We're physicians. And so our instructions is whenever somebody doctors who are referring patients are generally well-educated, well-meaning. They might not know what they're doing, but they're doing it with a good spirit, if you see what I mean. And even if we think it's a stupid question, A, we have to be polite, but B, you have to add value. So it's not good enough. Of course, if you take them and say, this is a malignant effusion, I'll do an aspiration, that's easy. But if you're not going to do a drainage, you should still add value and say, look, thanks for referring this patient with small bilateral effusions on the surgical ward. We're not going to drain them for this reason, but the reason they're hypoxic, because I'm a respiratory physician, is because their albumin is low and they've got pulmonary edema. I mean, you must add value. When you show that you're adding value, then people won't let you go and you just get more and more and more busy. But the key thing is we must not go down the pathway of some interventional colleagues, not perhaps in respiratory, but in other areas, that say, if I'm not doing a cardiac cath, it's nothing to do with me. That I'm very allergic to.
Josue, I will involve you now. So you started last 1-2 years. So the plural outpatient clinic or the consultation, and so what do you think from this really short experience? What has been the most benefits you have given to the patients and to our department with the implementation of this pathway for the pleural patients?
Our clinic started 1.5 years ago, by the end of 23. And I'm very relatable with what he have said in the beginning. We have to be really open access, and can be a little overwhelming because you're starting something new, and you have to have a good relationship with your colleagues and the ones referring your patients. And in the beginning, the oncology department was very happy with this new clinic. It was a really nice experience. And then we also articulate with them how we manage malignant pleural effusion, when they need to refer. And now we're working really well. Of course, in the beginning, there's a lot of paperwork, and it's really difficult to get a new ultrasound machine, materials. It's really, the ultrasound, it took 9 months to come, and needles, new chest bores. So yeah, that's really challenging, but then we can see the benefits because patients are followed more closely. And I think the IPC and the new conservative management of pneumothorax created this need, because if you see a patient in the emergency department and with a pneumothorax and you discharge him, you need to follow him. And before, we didn't have a clinic, we didn't have a structure, clinic and staff to follow that patient as an outpatient. And then we didn't measure the benefits yet. It's really just 1.5 years, and we are doing some tweaks here and there. But I think the waiting times to the diagnosis are really lower, because now, before, the oncologist would ask for refer the patient or call the emergency department for a diagnostic or therapeutic tap. And now they know about the clinic, they call us, the patient comes the next day or in that week. We are fortunate enough to have a space of our own, and it works. We have a nurse every morning and in the beginning of the afternoon. So the more patients they refer, the more we do, if we can, of course. But it's very rewarding, yes. We're just not yet at the point where we can measure the before and the after of the implementation of the pleural clinic. And I would like to ask Naj or Hihab, if you have any data after you started and implemented your clinic, there was what were the main outcomes that you see, like reduced time to diagnosis, fewer time to pleurodesis? I don't know, just guessing.
So, I mean, Josue, I think our pleural service has been established for so long now, 22 years, that we haven't really measured stuff in terms of a pre-post. What I can tell you, though, is that there is some decent data in the literature, actually. A couple from the USA. Surprisingly, the USA does not have very good quality pleural services everywhere. And there's some decent publications from people like Chris Gilbert and others showing really beautiful outcomes, such as length of hospital stay reduces, definitive pleural intervention in malignant effusion more than doubles in proportion. I can send you guys all the references. You reduce the number of unnecessary further pleural interventions. You reduce the amount of trapped lung one actually shows, which is amazing. And then there's things like time to diagnosis and so on. So I guess we haven't done a comparative measurement in our service because it's so historic, but the point you're making is very important. Your data is your friend here, because there's just no way that your service is not going to have enormous benefits. The key thing is to measure right from the get-go and be able to develop that stuff. Be useful. So I think Ehab's voice is more useful here than mine, actually.
No, I completely agree. And Josue, actually, once you do it, you'll see exactly that. It's almost doing it, but knowing exactly what the results will be, because by definition, your every patient you see in the emergency department that then you can ambulate, that's one less bed occupancy, that's one less inpatient admission. The number of people who sometimes we come across who didn't get referred to us, for example, on initial presentations, who have had, unnecessary, procedures or, tests that they didn't need. So fewer unnecessary CTs. I particularly look at sort of chest x-rays and tests and blood tests and other things like that as well. But then ED visits and admissions, I think, are a big ones, because those are the ones that, your hospital cares about, that cost a lot of money. And it all boils down to that in the end. So, and again, obviously efficient use of the outpatient capacity, I think is a big one. And of course, by definition, you will be doing that. I think I wanted to kind of follow on from what Nige said. Is we saw something really interesting at the end of sort of our 18 once sort of, I think when Denisha and who's my other consultant colleague and I had sort of been running together for about 18 months or so, we started to kind of see that actually we were doing a lot of quote unquote additional work, which obviously we were happy to do. But then what you start to see, we have to do for the benefits of the patient. But then what you start to see is almost that people start to sort of take things for granted a little bit, and then just assume that because Josue, because we know you care about patients and you will do the work, then that's fine. I just wanted to sort of bring up the point that in terms of sort of service expansion and service growth, it's really important that you sort of tread a fine line between this. And sometimes what you have to do is kind of, you could either say, okay, look, our capacity offers us the ability to see, for example, 6 patients a day or 8 patients a day. If we have to see an additional patient, either that means we take a less urgent patient off that list, which is, again, or we may need to admit someone, for example, that we can't discharge, or we have to get, or we have to, for example, cancel another activity to be able to accommodate this. There has to be some, because what tends to happen is then that it's because the problem is you have to play, and obviously I'd be really interested to hear about sort of in terms of the healthcare system in Portugal, certainly for the NHS, and Naj can attest to this as well. In terms of management, if physicians are willing to do something, people will just hide and just stay quiet and watch you carry on with things. But I think what we had to do is, for example, say if a patient comes in and our list is full, then that patient needs to be admitted. because we don't have extra capacity. And then suddenly, even though we don't want to do that, but sometimes you have to do that. And then you have to sort of almost be a little bit strategic about then allowing sort of, additional income, one of the additional sort of income and growth and investment to happen. One of the other things we did, for example, that was I refused to start, for example, a pneumothorax ambulatory pathway until I had agreement from my hospital that I would get a pleural specialist nurse, because I said simply, yes, I can do an ambulatory pneumothorax pathway. There's good evidence for it, but I don't feel that I can safely deliver that service to patients without having a pleural specialist nurse that they can have access to and be able to monitor outside of me being directly able to see. And obviously the hospital then wants to reap the benefits of all these ambulating all those pneumothoraces and all these people that they don't need to admit for chest drains. But then there has to be also a bit of a give and take as well in terms of that. And part of, I think, growing your pleural service is understanding that sort of strategy as well of how you can work that within your healthcare system.
Hey, let me take that last comment just to wrap up and with two final clinical scenarios. So how the pleural service can improve the approach of and management of you were saying pneumothorax. So I'll take you for the pneumothorax, then Najib can comment on that, and then the second clinical scenario is malignant pleural effusion. So in these two cases, how the pleural team can improve care. It's just about reducing hospitalization. So what are your final comments here in a more practical view?
So,
sorry, go on, Naj.
No, you go first. You have no problem.
So I think for pneumothorax, I think a lot of the recent data and what the recent guidelines, I think, on pneumothorax tell us is patient priority and patient preference, and symptom guided care, I think, are really a priority. Now, I think the benefit that we have, obviously, with our understanding of the data, our understanding of the guidelines, is that we're able to, first of all, have a much more informed discussion with patients about decision making in terms of pleural procedures and pleural management. For pneumothorax cases particularly, I do find that when you have a pleural service, I think you have the ability to offer a range of managements as Naj described in his talk. But also, I think what is important is to make that decision based on the patient's individual circumstances. So what their priorities are, where they live, how mobile they are, how easily they can access hospital in the event of a problem. And I think you absolutely cannot do all those things without the infrastructure in place to be able to do that. For example, a dedicated, pleural nurse for the patient to be able to contact, if they run into any problems, an ability to be able to see the patient in a dedicated environment, for example, early access to investigations, addressing the complications within a device as well. Because, for example, if you, Helder or Josue or Naj, for example, you put in a pleural vent in a patient and let them go home, that you've done a good thing. But then if the patient comes back and then there's no service in the hospital and nobody to understand what this device is, there's a complication, there's surgical emphysema around the chest, and there's no one who understands what this device is, what they can do about it, then you haven't really helped the patient. And that's probably, I think, how I would summarize the answer to that question. Naj.
Thank you. So if I do malignant effusion, Josue, I'm just going to go back to something that you said earlier about how do we demonstrate benefit. Look, I think I'm just going to zoom out from malignant effusion first. The thing is, we should be advocating for our patients and advocating for them having access to the right treatment that's evidence-based. If I was to use the cardiology example, if somebody came into my hospital with an ST elevation myocardial infarction and I didn't call the cardiologist and they didn't get a cath, you know exactly what would happen to me. Everybody would shout at me and say, this is not acceptable, this is not. So actually, without being aggressive, we should do the same. If we see a patient who's had 6 pleural aspirations, undiagnosed effusion, we should have a word. And we should say, you are not following the evidence. The patient has been put at risk 5 times. They should have had a pleural biopsy a long time ago. And you could do that because the evidence base is now so rich. We can do that in a polite way across multiple areas to enforce that our patients deserve good care. And we shouldn't, as respiratory, sometimes pulmonologists are too nice, I think. We sort of think, well, they tried their hardest. No, there is an evidence base and people should follow the evidence base. And if they don't know it, then they should call you or they should call Helder and ask them what the evidence is. So that's my first point. In malignant effusion, it is all the way from the start to all the way to the end of their treatment, in my view, where we add massive value. So diagnostics, I've given you an example, not doing the wrong diagnostic because it's in front of us, triaging patients to the right biopsy strategy, thinking about biopsies and diagnosis in the context of the patient. Should we be pushing this or not? Thinking about molecular analysis, all of this belongs to us within the Pleural service and we add enormous value. The treatment, again, in Ehab's excellent talk, of course, you've now got options, aspiration, talc pleurodesis, IPC, but it's the decision-making that's more important in my view than the interventions. You can teach anybody intervention in a day or two. It's not difficult. It's about how do you pick the right patient for the IPC? What happens when the IPC blocks 6 weeks later? What about the patient with terrible pleural pain 3 months after IPC insertion? That's where we're adding enormous value and where your team and contact by oncology or the patient becomes absolutely critical. That's really a service. I'll give you another example. I know of hospitals in the UK that don't have pleural services where the radiologist put in the IPC. And we literally saw a case not long ago where the radiologist put in the IPC. The patient wasn't given any instructions. She stopped draining 2 weeks later, and it stayed in her chest for 6 months, just sitting there doing nothing. So then moved to our area, we got in and it was this absolute mess. Of course it was. This is unacceptable in my view. We should be shouting at people about this. If you're going to put the device in, you have to look after the patient and the device. As far as I'm concerned, if a patient has an IPC in, they belong to my service for as long as that IPC is in. And I'm not saying that we'll see them every day. We're not their GPs. But if they have a problem, they need to feel looked after. I'll just comment one further thing. We did a survey of patients in our pleural service a couple of years ago. We have to do this to do something called revalidation in the UK. So we've got to ask patients what they think and so on. The number one comment patients made about the pleural service in Oxford is not you've got evidence-based randomized trials or that you've got professors. The number one comment was we feel looked after. That was the number one comment. And the number two comment was we know who to call. So if you solve those problems, yeah.
That's a great idea to end this episode. Thank you very much, Najib. Thank you, Ehab. Thank you, Josue. I think with these final comments, I think that we will stimulate the audience to think about the pleural service and how to strengthen the workflow of all these patients and to improve their care and continuous care. So that's really, really good, really enlightful. And thank you for joining us. And I will just say goodbye to our audience in Portuguese. Muito obrigado para os que estiveram aí desse lado e continuamos no próximo episódio com mais um tema a propósito da pneumologia da intervenção. Vemo-nos no próximo episódio. Muito obrigado.